So, hello, Goldacre surgeon. So I'm going to be describing simulation of needle thoracentesis for the emergency management of a patient who we've already determined that they've got a tension pneumothorax. So it's an emergency situation. Tension pneumothorax obviously is life-threatening. So this patient will go through, in a lecture what a tension pneumothorax is, why it's so dangerous, but actually the treatment of this is critical. So this is a simulated patient, supine, in an A&E resus, but this could also be done in pre-hospital care, so it could be done with the patient in multiple other positions, so they may not be as lying as flat as they are, they may have other injuries going on, but you'd need to treat tension pneumothorax really rapidly. So if that's the case, then you need to make sure that while you've got this in your brain, that tension pneumothorax is the diagnosis. You need to get your kit, and the kit's pretty simple. So the kit is a big Venflon, so grey Venflon, something to clean the area, a syringe. You may need some local, which is fine, or the patient may be collapsed, in which case you don't need any local. You basically don't need a scalpel, all right, for this particular procedure. And while you're doing this, you also need to make sure that you've got some observations on if you can. If you're in a hospital setting, if you're part of a trauma team, then you're discussing with your trauma lead, the rest of your trauma team, your MDT, who are around as to what other parts of the trauma team are doing at the same time. And then once you've done this, you then have to reassess what you've done to see what the benefit to the patient is. If you've got the diagnosis correct, is it worked? Do you need to repeat it? And the end goal for this is to be life-saving for tension pneumothorax, but then also to work out what to do next. And the next stage always, if your diagnosis is correct for tension, is to do a chest drain. So simultaneously, if you can, if you've got helpers or colleagues, is you get the tension pneumothorax sorted with the needle thoracentesis, and at the same time you're getting the chest drain kit ready, just so that while this is put in, it's really quite unstable. So you don't waste then time to get the chest drain kit. So that's all the pre-stuff. All of that should have happened instantly. So once you've got the patient in place, you've got them supine, you explain, if they're conscious, you explain what you're going to do. You give them local anesthetic if they're conscious, just to make the area numb. You clean the area. So I'm cleaning the area on the anterior chest wall. And this basically is from the center, from where the sternum is, the manubrium is. We're looking at the second intercostal space, and this is the mid-clavicular line. So your clavicle, mid-clavicle line, and the second intercostal space. So it should be fairly obvious to feel as a little notch, a little indentation, and you're trying to get above that rib. So I'm explaining it now to you in slow motion, but to do this in real life probably take 5, 10, 20 seconds, that sort of time frame. But to explain it is to clean it and then make sure your anatomy is okay. Explain to the patient, second intercostal space, mid-clavicular line, and then that's the notch that you're trying to feel. Make sure that you're happy with that. You've got your Venflon here. You take the cover off, and you've got the sheath, and you've got the metal spike. Take this bit off as well. And then you would put it into the space that we talked about. So it's going directly perpendicular to the patient, so right down, and you're going just skirting above the rib and pushing it right down here. So it's got to go right down, it's got to go skirting above the rib, so that you're avoiding the neurovascular bundle which runs below the rib. So you're taking out the sharp, and you may automatically at this stage have a hiss, maybe have blood splashing out, but you can also, either with fluid inside this, with some saline inside, or with an empty syringe, aspirate, and that's actually showing that you've got the correct diagnosis. Lots of gases coming out, and if you can leave it open, if you wanted to, the patient may regain some consciousness. You have to reassess the patient, go through the ATLS principles. Your tension pneumothorax, where everything on the mediastinum is shifted towards to the other side, would now come back more into the mid zone. The patient's vasculature would become more into normality, hopefully, if this diagnosis is correct. But this is where the needle goes. Now, if you were to hit the neurovascular bundle, which is below the rib, now that would actually make the situation a lot worse. So that would potentially make this into a tension hemopneumothorax. So internally, you've actually got blood inside, potentially arterial venous blood going inside, as well as a tension. So you need to avoid that. So what I do is, as I go over as I put the needle in with the Venflon, I actually touch it onto the rib, and I've touched it onto the rib, and I literally almost walk over and then pop it literally over, a millimetre or so over, just over the periosteum. And that's how close you've got to be, because the gap isn't that big, and the gap can be obviously hard to find with different body habitus. So you're going in just over the rib, you've avoided the neurovascular bundle, you've got your diagnosis. This then is unstable, so you need to get some sort of padding or some sort of dressing in place, sticky tape to be there. But the worry is, and the potential is, as that's been done, patients wriggling around or regain consciousness, or their arms moving, etc., that this then dislodges. It's not that big in reality. If you look at this one, it's not that big in reality, and your anterior chest wall could be deeper than that in somebody with obesity. So you may only just be in, and if you come out of it a little bit, then you're going to develop surgical emphysema. So surgical emphysema can be pretty impressive. So all this would be bubbly and crackly like a packet of crisps. All of this would rapidly expand, go up into the chest, into the face side, and you'll then lose this. So then this will be not working. The patient's tension pneumothorax will be back again. So essentially, you're back to square one. So if that happens, don't panic, don't worry. I would leave that one in and do another one rapidly. So you know where to go. I just go a little bit more lateral, bang, put another one in, but then you really don't have much more time. So then you really rapidly need to progress onto your chest drain, but that's how to do the needle. Thank you very much.